We are back with another PCBH Corner, and we have a great topic today. So we're going to be discussing something that was brought up on the CFHA listserv about the warm handoff workflow. And what's so interesting is I went back and looked at one of our previous videos that we had done on the warm handoff, and we talked all about the clinical function of it, which was super great. But even in the video, I had said like, hey, this is a whole other topic on its own. So what better time?
Let's stop going back and watching.
So what better time to do literally an episode on the warm handoff workflow? So
Love it.
I got questions for you.
Okay.
So I guess just kind of taking it face valid with that question, could you describe the warm handoff workflow that we have at CHCW, along with maybe some recommendations that other organizations should consider?
Yeah, and obviously stop me wherever your mind goes and points that I'm leaving out. I think the first part that we really tried to set out for was to have this be as simple as a process as possible.
Okay.
I love your rule. What's your rule about if there's this many steps?
I used to say if there was more than 3 steps, but now I'm honestly like, if there's more than 2 steps in the primary care fast-paced setting, it's going to be forgotten.
And let's look at that a little bit. Let's talk about why that is. And so when we think about workflows and different things, we always just got to think about like the probability of them actually being completed. And so each additional step that we add is lowering the probability that it's going to be completed. And so that's where we have taken this approach, and especially when you start to shadow and see what a PCP and MA has to do on a daily basis. Adding a workflow that is causing them multiple steps, causing them additional work that takes time, it lowers the probability. So I think the first recommendation that we would have for any system that is looking at this is just, one, make sure you understand other people's workflows, what a PCP's workflows, what a MA's workflows, anybody that's going to be involved in the warm handoff process, make sure we have a clear understanding of what
That's great advice.
The second thing then is like, how do we develop something that is easy, seamless, and efficient? So for our process, what we have is that we very much want it to be something that the PCP can just do very quickly and they can move on with their day. So this is one of the reasons why from the beginning we have BHCs sit where?
In the pods.
In the pods. And not only is that because of good team-based care and different things, that also is easy. If a PCP just comes out of an exam room, boom, they have a BHC right there that they get to say, hey, are you free to see this
That
patient?
bumpability is perfect.
Bumpability is perfect. So alongside of that, so basically the process is traditionally, and we'll talk about the other kind of approaches that we have, but a traditional handoff. PCP goes into the room, identifies a behavioral health need or a PCBH need. They work with the patient, patient's agreeable. We have 2 kind of workflows that happen. One is PCP comes out of the room, sees a BHC, hey, free to see this patient. BHC accepts the handoff. PCP is able to go on their day, after having maybe like a 60-second conversation about what's going on, able to move on their day to the next patient. The MA of that PCP then adds that patient onto the BHC schedule and checks them in.
Perfect.
BHC then goes and completes the visit.
Okay.
Say the PCP comes out and there's no BHC in the pod because they're seeing other patients. PCP says to the MA, hey, I need a BHC for exam room 9. That PCP then goes on with their day. They can go, if it's a resident, go precept. If they're an attending physician or an APC, they go on to the next patient. The MA then sends out a Teams message to all the BHCs. We have a requirement that you need to respond as a BHC within 3 minutes of that request. Now, honestly, I think it's more like 30 seconds, 60 seconds. Very rarely does someone take 30 or 3 minutes. Everybody responds with if they can get the handoff, and that usually is ATS, which means add to schedule. I'm claiming that handoff, or everybody responds with their estimated time, which is usually anywhere from 5 to 15 minutes that they're going to be there. Whoever the BHC then is that is accepting that handoff, the MA again puts the patient on their schedule, checks them in. The BHC may come over to the MA station and say, hey, do I need to talk to the PCP? And if the PCP's in with the patient, knock on the door, interrupt them real quick, get a 60-second conversation, no more than that, and then the BHC follows up. So those are kind of our 2 formats of the traditional pathway. Anything I missed? Anything you want to stop on?
Yeah, a third one that I've seen a lot of PCPs utilize is that when they're in the room and it's looking like the warm handoff is going to happen, or they really want the warm handoff, is or they've already pitched the warm handoff and the patient is accepted, they teams the medical assistant to get started on it because that could have been maybe in the middle of their visit or even towards the end, but they can get a jump on it. So even from the room, they can send a Teams message to the MA, and then the MA gets the BHC there. And so, you got to be a little bit careful with the timing, because if you do in the very beginning and say, okay, the BHC is ready, then the BHC comes over, claims it, and then they come over and it's like, oh, well, they're still going to be in there for another 15 minutes. Then it actually...
Say another handoff comes in and the patient's ready, yeah.
And our general rule is first come, first serve, so you can't really claim it. So it has to be within reason, but I have seen a lot of PCPs very successfully do that. They did that in the middle of their visit or towards the end of the visit, and were able to conjure up that warm handoff. And, and it's not wrong to do. It just might be a situation where you cause yourself some more work, because if another handoff comes, the BHC takes the other one, then almost that handoff needs to be resent to the pool.
Things to highlight about that process. No one involved, the PCP, the MA, or the BHC, has more than 2 steps to the entire process.
Ooh. Oh yeah, walk me through each of those.
PCP, the only step that they literally have is that after they identify the need, is that they are walking out and either they have the BHC waiting there, or they just tell the MA, I need a BHC. Literally, their process is done. So that's one step. Them walking out of the room, telling the BHC that's sitting in the pod, or the MA, I need a BHC. The MA, if they receive that request from the PCP, they have sending out the Teams message to it, and in every scenario, the second process would be adding the patient onto the schedule and checking the person in.
Perfect.
BHC is obviously you just got to accept the handoff, or if it's coming via Teams, you respond with your ETA, which is the first step, and then the second step is basically doing the handoff.
See the patient.
See the patient.
Now, a really important factor in this that we haven't highlighted, which that was really great, by the way, is how do you know which BHCs are on? So in our system behind the scenes, we have the scheduling system that goes out. And in the morning, when the medical assistants and the nurses are creating in the pod who all is going to be there. So they're assigning the rooms for the PCPs and medical assistants, which nurses are going to be there, which preceptors are going to be there for the residents. They sometimes have some other information. And right then and there, they will look on the schedule and see which BHCs are on.
Huge.
Because in our system, we have multiple BHCs. And not every BHC works all 10 clinics. That'd be a morning and the afternoon for the 5 days, equaling the 10 clinics. So in those cases, what they need to do is look on the board. And so in the morning, it might be Beachy, Bauman, Ortner, and Shepherd. In the afternoon, it could be Beachy, Ulmer, and
Shepherd.
Yeah, Shepherd. Yeah. So we can go from there. So they just have to pay attention, and when they're making the board, they have the morning and the afternoon clinic.
It's such a huge, I'm so glad that you said that, because this is another ease of the process, is that MAs can't go searching like, hey, if we're using Teams, who's on today? Like which BHCs are on?
I would honestly even say to do that, even if you had 1 or 2 BHCs.
I agree completely.
Because what if they're on CEU? What if they're on PTO? What if they're sick? All these different things happen. You need to update the board.
And it's almost another subtle way of doing bumpability, that by writing up on the board next to all the PCPs, the BHCs that are on, there's a kind of subtle bumpability that is naturally occurring, because you're always looking at that board. Oh, these are the BHCs that are on.
And that one person that was assigned to set up the board, that's one person doing all of the work.
Correct.
Now it's on the board. And so, yeah, I love, nice. Dave, how you broke it down into those I guess there's 4 stakeholders. So there's the BHC, the medical provider, the medical assistant, and the patient.
Absolutely. And again, what's really great about this, patient, really no steps as far as the ease of the transition of the things that are going on behind.
Every once in a while, you might have to be moved to a room as a patient, but not a big deal. You literally accept the BHC, and then you do the visit. And then as the BHC, you say when you're going to be there and accept it, or give a like for somebody else who's accepted it. As a PCP, you've identified it and you've pitched it. And once the patient accepts, you ask the MA to do it. And then the MA, it's already on the board. You look and see, okay, who's on the board? Put that in the Teams. Whoever accepts it, now you're adding them to the schedule. So every year, I love that everybody has no more than 2 steps.
And the thing that I was going to also highlight that you were just saying there about how there's standardization across the board. Everybody does this the same way. And now you and I, we're not necessarily big standardizing people indiscriminately. Like we like autonomy, we like people doing what it's like. This is one though, so anytime a new MA is onboarded and trained, they're trained in this. Anytime a new PCP is onboarded and trained, they're trained in this. Anytime a new BHC is onboarded, they're trained in this. That this is the workflow, and it's a simple one, it's an efficient one, and we're constantly giving feedback. Particularly the feedback we always are looking for is, hey, are BHCs responding to that MA's request?
Right.
Are we getting there quick? But it's giving that feedback because, like, is there every time that we can iterate this process to even make it a more simpler version of it?
And one of the big shifts that we had just as an organization to truly go towards integration is in the beginning, it was almost kind of like, here, let me do all my MA duties. Let me learn my MA role.
Yes.
And then once I learn that, I'll add on this BHC thing. Now in our system, those things are not separated out. As part of their standard workflows, standard processes, when you are an MA, the same way that you're going to do anything with regards to vaccines for the PCPs.
Taking weight and blood pressure.
It's the same across that you're taught, okay, and this is what you do with BHC.
Huge point, because BHC is primary care.
Yeah,
and that's a reflection of it.
Not an add-on, it's not a separate service.
And it's not one individual that's like assigned to it that is going to be able to, like there's one MA that is the only one that's going to, send out the handoffs or to do people on the schedule. This is an expectation of basic job duties of the MA.
Yeah, and I love the way that we have it. I know I've said it like 4 times now, but I want to say it a fifth. I love the way that you have it broken down with each of the stakeholders, because it's not this insurmountable thing that when you go to think, oh, I have to do this, it's like, okay, I have all these steps. Each and every person, we're trying to make it as seamless as possible. So once again, even from the patient's perspective, it's like, hey, I need to see BHC today. Oh, well, we got to do X, Y, and Z, and on and on and on. It's like, no, the BHC is going to come in. They're going to do the verbal informed consent. You're already going to be on the schedule. They're going to walk you through what needs to happen. And then you just do the visit.
And so 2 other things that my mind goes to. One, I want to talk about maybe the non-traditional. That was like the traditional kind of like when you think of a warm handoff.
Yeah.
But before we do that, the other thing that's really great about this workflow is how much have we been able to generalize this to other team members, right? So our front desk staff, say a patient comes in to the front desk and they're kind of having a difficulty, they're asking to see a BHC and stuff. What's the process?
Same thing. You're going to look and see on that schedule, because they have access to that to see which BHCs are on, and then they send them a Teams message, and the BHC receives the Teams message, and just like anything, you have up to 3 minutes, but honestly, it's more like 30 seconds to claim the handoff.
Call center, same process.
It's the same process.
OB team, same process.
It's the same process.
Connect in our medically assisted treatment,
same
process. So every single group we've been able to generalize this to, and I think my mind says the reason why it's so generalizable is because it's efficient, it's easy, it's something that is standardized, everybody's used to it, and so forth. So let me ask you this. Let's go through these non-traditional kind of workflows of.
Yeah, I'm interested to see what you're going to bring up.
So the one that my mind always goes to is in the really emphasis on making sure people are huddling in the morning, scrubbing schedules and charts. What happens when a PCP might be running a little bit late or behind?
Yeah, that could be an opportunity to do a cold crash.
Yes.
And if you were, back to your point about the scrubbing and huddling, if you as a BHC had identified alongside that PCP and got permission for, hey, I think this person would be a really good candidate, or this person's on an SSRI, or this person is dealing with chronic pain and they're on a pain contract. So if I'm running late, you could go ahead and get started on this visit because this is medically necessary for our work together, or for the patient's overall health care. And so you get that green light, and if there's not a lot going, you have a cancellation or maybe an opening in your schedule, or you're free, or you really just want to make sure that patient is absolutely offered this service in real time, then you could go ahead and get started on that.
And again, during the huddle, obviously the MA is going to be included in this. And this is where it's kind of neat, is that the workflow stays the same. You just might enter the workflow at a different point.
Yeah, well, walk me through that.
So if the MA is aware that, hey, this patient, if the PCP is running late, the PCP wants the BHCC. As soon as the MA is rooming that patient, they can initiate the workflow, which again, same thing, just picking up from where the MA is. MA sends it out to the team. Hey, we have a patient, blue team 9, handoff, ETA. And so all those different things.
And then they would put on there probably provider hasn't seen them yet.
Or cold crash, that this would be a cold crash that's requested. So all those different aspects of, while it might be an initiation of the workflow at a different point.
Yeah.
It's still the same workflow as far as just where you're picking up that you're entering that workflow.
Yeah.
So I really like that, and I like this discussion. And again, it's not to say that people have to mirror our process. Some people might not use Teams. I mean, remember back in the day, what did we use?
Well, we used an email that would ding to your phone. So the person requesting it would be on email, but the request would come to your phone. So it got a little bit crazy.
Same process though. It was the same process. The MA would pull up the email, send it up to the group, and then you would respond back. It was terrible looking back on it, but.
And to answer some of the other questions with kind of the different approaches that had come through on the listserv, and I think Mike Bruner had talked about this, and probably Rob, some other folks had talked about this, of just kind of whatever makes sense.
Yes.
Oh, and Cody too. He had put in the pros and cons of each, of going in first, going in same time, and going in after. In Washington, there's billing requirements that you basically can't bill at the same time. So we be a
Meaning that you can't, the time that's kind of shared, you have to be the active participant, and that you can't double up on time.
The co-visit, I should use words that make sense. The co-visit is one that we can't, you can't bill for medical and then double up and bill for the BHC. Now, that doesn't mean that you would never do it. You would just have to be a little bit more prudent, and you'd have to be very, very intentional. If not, you're not going to probably have that just be as a regular one. As far as going in first, that's a great opportunity if the PCP is running behind also new patients.
Yes.
And as Mike Bruner had put into the CFHA listserv, that's the way that I prefer, because I can make things the easiest for the PCP and for the patient and for myself, to be completely honest. I think I can kill all three birds with one stone if I go in first. However, you need to respect the team and what makes sense. And there might be some times where it makes sense for the PCP to go in first.
You know, and I really love that when we talk to, Dr. Stedman, our site director at CWFM, and kind of a de facto BHC.
Right.
So she always says this. She's like, when you all go in first, it helps me out. It really helps my visit. And I really do love how you said, like, it just has to be a communication and a conversation. And as a reminder to the BHC that if you are going in first, the last thing we would want to do is then also hold up the PCP from being able to do those visits. So there might be times that you might have to pause a visit or wrap it up very intentionally if the PCP is ready, maybe come back in after the PCP is done with their visit to wrap up yours, but being flexible with time, your approach, what you're doing. But definitely those visits, when I get to go in before the PCP, undoubtedly, the PCP feels a lighter weight heading into that room, and it's a more efficient visit for them. Typically.
And there's so many nuances that are like running through my head of ways of increasing that efficiency with, like you were saying, if you're going to go in first, kind of being ready and knowing how to wrap up a visit. It's another thing that's popping up in my brain is making sure to actively do the after visit summary as people are bringing up ideas, having them written down right then and there. And so that if the PCP were to pop their head in and you say, okay, we're almost done, promise, just need 5 more minutes, you can finish up your after visit summary and finish the visit. It is a skill set. I would say a very specific skill set. And who knows, we might need another corner on this.
Well, I was thinking another corner, maybe even a demo, a demo about how, because I also love those moments of when the PCP enters the room, I'm able to then describe to the PCP what I just heard from the patient. It's a beautiful thing that it's like the three of us now saying, hey, this is what I've heard. This is also what the patient is really hoping to follow up on today. These are the goals that we already set. It's a cool thing to happen like together. I think we should do a demo video.
It helps with the efficiency on all fronts.
Yeah.
So you're making the most of the patient's time, you're making the most focused use of the BHC's time, and then you're in the moment handing it back off to the PCP, and there's, everybody kind of feels satisfied in that situation. So it doesn't always go perfect like that, but when it does, you can feel that flow.
So key takeaways, I think, about these, handoff workflows. The main thing, as we said, one, understand the context of the people involved. It can't be a complicated context. It can't be something, or workflow, it can't be something that we do this the one time, we do this another time. It's
standardized, two or less steps that everybody knows.
It's efficient, it's purposeful, it's intentional. And the one thing that we kind of talked about, but we didn't talk about, making sure as us as BHC, we get those handoffs. We're very responsive. We get those handoffs. So any last final thoughts that your mind goes to?
I'm just excited to see what y'all think and if this was helpful. And I'm assuming that this video might prompt some more questions and might be some fodder, like we're saying, for possible demos as well as possible other PCBH corners.
I love it. Well, as always, thanks for stopping by. Definitely let us know where your all's minds go.